In section 3, we're going to look at naming HIV to a child. It's important to contextualise this in history because historically children were not told about their HIV diagnosis because they weren't expected to live. And all around the world, we see people struggling to tell others that they have HIV through fear of being rejected, discriminated against and abused. And this fear has silenced families. I've seen it in every country I've worked in, that HIV is not discussed and it's seen as something which is terrible and sad, when actually it's now a long-term health condition. And all of this can impact on the child and young person's ability to understand and accept their own HIV and manage their own health. And because of all of this, in 2011, after 3 years of extensive research, the World Health Organization produced guidelines which recommended that children be told that they have HIV by the time they are school age. And this was defined as 6, encompassing children up to the age, under the age of 12, but ideally between the ages of 6 and 8 or 6 and 9. And the guidance also pointed to research that had indicated that not telling a child their HIV status may lead to or exacerbate depression, worry, and other negative mental health outcomes. And this would potentially interfere with their treatment and affect family life, including parenting ability and the child's social and academic life. So basically, the World Health Organization saw that children not being told their HIV status was having a detrimental effect on them. And one country that stands out with the way in which they manage naming HIV is Sweden. And in 2009, 2 years before the World Health Organization's recommendations, the University Hospital in Stockholm decided that they would change practice, and HIV was, from that point, was spoken about openly with all new patients, regardless of the age of the child, and that children and parents and carers were spoken to and still are spoken to about HIV openly at every clinic appointment. So it didn't matter whether they came with a newborn baby, with a 6-year-old, with a 9-year-old, with a 15-year-old. Everyone was treated the same, and HIV was treated as every other medical condition in that hospital was, and spoken about and named. And the key aim of this model was and still is to reduce anxiety and to give the families and the children hope. And all the questions that were asked by the children are always given honest answers, and attention has been given to not using stigmatizing language. And I'll look at this a bit later on. And importantly, the children are never told that they cannot tell another person, but they are asked who would they want to tell. And then this is explored with the child, so they take part in decision making, and they decide when and where and who it will be good to tell. And through this, they're not telling the children that HIV is so terrible that you must never speak about it. They are getting the child to consider who they would want to share personal medical information with and how they're going to do it. And if we briefly look at the general principles of child-centred communication before we look at actually naming HIV to a child, we have to always remember the age and cognitive ability of the child, which may not be the same. And as I spoke about earlier, thinking about reflective listening techniques. So not only are you listening to the child and reflecting back what they say, but you're asking the child to reflect back on what you say. And that you need to give the same information in different ways because the child is developing, and at different points they will retain different parts of information. So for example, if you're talking to the child about medicine and treatment as prevention, at the age of 10 or 11 or 12, it may not be important to them that if they take their treatment and have an undetectable viral load, it means that they are very unlikely to pass HIV onto a sexual partner. But if this is brought up at the age of 13, 14, 15, it will become much more relevant. And so information just needs to be continually gone back over. And it needs to be clear, it needs to be simple, and it needs to be the facts. And all of this needs to be done in the context of being child-led and that it is non-judgmental. It is not for you to decide what information you feel because of your beliefs the child should know. It's about giving the child all the information that is out there. So I want to show you a very quick video, which is just of the resources that I use when I'm naming HIV to a child, and also when I'm getting the child to try and understand how medicine works. So you can see here that I'm making white blood cells, which I call white blood cells, CD4 cells, and the child's immune system. And when I'm explaining to the child how the immune system works, I use all the different terms because they may hear different ones in hospital. And here, out of a piece of green paper, I'm making some little HIV viruses. And I say to the child, do you know what HIV means? And I explain the letters. And then I try to explain to them how HIV works against their immune system and how the medicine then supports their immune system. So here we see the virus going into a CD4 cell and replicating. And through that process, it pops the cell. So it uses the energy in the cell. And then it keeps doing this throughout the person's body until their immune system's quite weak. But then the medicine comes along and it helps to put the HIV virus to sleep so that the immune system can grow strong again. And then here we see a strong immune system. And in this very visual activity, what you're doing is you're explaining things to the child. You're using correct medical information, but you're also giving them visual prompts. So they're learning using all their senses. And then you get the child to reflect back what you've told them. So I show the child, and then I ask the child to show me. And all the time I'm calm, I'm not emotional, I don't talk about anything other than the facts, but I talk about the facts in a simple way. And so there are no monsters, there are no baddies, there are no battles, and there are no wars. And we know historically these images have been used for children. But then what they're telling children is that there's a battle going on inside their body. And this doesn't support them to develop a positive relationship with their health. Just using simple medical language, facts, reflections, and open conversation. This is the child's body, and they need to learn how to look after it. And there is HIV stigma in the world, but that should stay outside the door. When you are having these conversations with the child, it should be child-centered and about their needs. And their needs are to know about all of this, to understand it, and to be able to then move forwards in their lives. So we should be equipping children with the knowledge and information to live and thrive in this world, and not have the information that they need hidden from them.